Again, just want to thank everyone for joining tonight. If you have any questions or concerns, if you want to reach out for any advice, my contact information is there. I've had a few people after the intro class last time reach out and help them with a couple cases, and yeah, it's fun to collaborate. But yeah, so tonight we're talking about one of my favorite products from New Smile. It's their Zirconia crowns. Background of my experience, I've been offering zirconia crowns in our office for almost 10 years now. I did mostly strip crowns in residency. Did some strip crowns in private practice. But unlike residency, got a little bit more follow-up, got to see these cases long term and realized that there's probably a better, more efficient, longer lasting option out there. So I took a couple workshops with a couple different companies and started my journey with zirconia crowns. Um, Probably placed around 6 to 7 thousand so far. Um, and ultimately, through all of this, in the end, I've been most satisfied with New Smile. So we'll continue on. A little bit about me. I've been married for 17 years come April. These are my two beautiful children, Tom and Mila. Tom's 6, Mila's 4. I'm based out of Amarillo, Texas. It's the in the Panhandle up in the Northwest. I'm a partner in a multi-specialty, multi-office group. We have 5 locations, a triple HC ambulatory surgical center, 8 pediatric dentists, 1 full-time orthodontist, some part-time orthodontist, oral surgeon, and then these are my 2 business partners, Dr. Mike Ross and Dr. Devin Cooper. Dr. Ross is an orthodontist, and Dr. Cooper is a pediatrician as well. Went to Tulane University, got a bachelor's and master's in neuroscience, took the NCAP, got into med school. That was the path I was on. Then Katrina happened, which kind of changed my plans. Decided to stay in New Orleans and teach math and science for middle school kids in Marrero, Louisiana, and then kind of found my way into dentistry, and then went to Texas A&M for dental school, and then Children's National Medical Center in DC. I'll be out here to talk about the zirconia crowns from New Smile. Disclosure, New Smile has provided financial support for this presentation and materials for the practical training of pediatric dentistry. Some of the all the cases are pretty much mine, but there are some images from other New Smile clinicians. But yeah, I'd be happy to do this whether I was getting paid or not, because I love talking about it. We'll kind of skip through this. This is just, the reasons why we do full coverage restorations, and everyone is very familiar with this. So we'll move on. Types of full coverage crowns: stainless steel crowns, open face crowns, pre-veneer crowns, monolithic zirconia crowns, a couple different options of ones that you can bond to the tooth. Again, my background is composite strip crowns. I have done porcelain fused to metal crowns, of course. Don't like those. They're super bulky. They're not aesthetic. They look like chiclets. I'm not a big fan. But yeah, so I pretty much exclusively only use zirconia crowns in my office. Let's get through this. There we go. Here's an example of a case from Dr. Matt Lucero. He's based out of Denver. Yeah, immediate post-op in the GA setting, but very aesthetic, minimal damage to the gingiva. Perfect example. And we can talk about a couple advantages, disadvantages. A lot of this everyone should be very familiar with. We know the superior aesthetics. We know it's very soft tissue compatible. There's no metal show, of course. They're durable. They're great for crossbites. I've used it on multiple anterior crossbite cases, and I've not had an issue with it, which has been great. There's no nickel. Minimal chair time with practice. Good case selection is going to be really important. First few cases, obviously avoid crowding, space loss, pulpal involvement. Obviously pick patients with good behavior. If you have the ability to do it in a general anesthesia setting or in a sedation setting, it's a good area to do your first few cases as well. But learn the prep, learn the fit before attempting more difficult cases. Today we will be going to some more advanced cases that have been done chairside too as well. My goal is to show mostly cases that are always done on nitrous, because not everyone has access to the OR, or a lot of people have limited access. But I will say this, you'll never be able to do it as fast as an SSC in the posterior. but I do believe you can be just as confident when recommending to a parent when you make when you're particular of which cases you want to do them with. Autoclavable, they can color change over time, but as you do more of these and you learn your sizes, um, you can almost always guess the correct size just by looking at the tooth before you start the case. And then disadvantages, of course, you can't crip them. Um, saliva and hemorrhage must be controlled. Certainly, there's a learning curve at the onset and the cost. But yeah, I think the cost is kind of a minimal disadvantage, knowing that once you've placed it, it should last for the lifetime of that tooth. These crowns do come with a little notation on the back of them. At first, I wasn't removing because it's like half of it is subgingival. But we did get some feedback from parents that didn't like it. So now I do remove it. I just use a little diamond football ball. Diamond football, very simple to remove. So what is the relevance of gloss on zirconia surfaces? Let's get all that out there. So the key point here is the new smile crowns are highly polished, which results in less plaque buildup. They're easier for cleaning. There's better aesthetics, creates less abrasion and attrition on opposing teeth. Other brands do hand glazing, which we'll discuss later. That does affect the durability of the crowns. Yeah, we'll get more into that in a little bit. Again, zirconia is highly biocompatible, confirmed by numerous studies, makes it an ideal material due to its minimally adverse tissue reactions. Again, highly polished crowns, so they're chemically inert, they're biocompatible, they promote good cell adhesion and prevent plaque buildup. But I think this is a perfect example of that. You can see the plaque buildup on the natural teeth and on the SSCs, but not on the zirconia crown. So this is a beautiful example of how well that high gloss prevents the plaque buildup. And yeah, I got to remember that I got to get all this out there. Okay. So how strong is zirconia? Studies show that zirconia exhibits significantly superior flexural strength compared to natural tooth enamel, making it highly durable for restorations, but potentially more abrasive to opposing natural teeth if not properly polished. That's why there's such a large emphasis on the highly polished finish. And then again, getting into the nitty gritty here, but this study showed that a new smile zirconia crown opposing natural primary enamel maintained a normal wear rate equivalent to natural primary enamel teeth. Only times I've seen very noticeable wear on zirconia crowns is if you leave the posterior crown in hyperocclusion, you'll certainly will see that. And I've also seen it in cases where where I see it the most is when canines are left in hyperocclusion. A good tip though, if you do have a crown that's seated well, but you do notice that it's a bit in hyperocclusion, the crowns are a bit forgiving. You can smooth a bit of the crown on that high occlusive spot. You can also do an enamelplasty on the opposing tooth. Um, the great thing about these new smile crowns, though, since we've switched to this brand, I have not had a fracture yet from either trauma or from clenching and grinding on a tooth where it's not in perfect occlusion. In the past, we've had a few cases in post-op and recovery where a patient is clenching and grinding down on their teeth, and they've fractured canines and stuff off. And does not make for a fun day in recovery. But the great thing is since we have switched to New Smile, I have not seen these problems just due to the amount of fracture load that they're able to withstand. Another study here basically just showed that new smile zirconia crowns opposing natural primary enamel maintained a normal wear rate equivalent to natural primary enamel to natural primary enamel. So they hold up really well. Again, the only time I really see them being worn down is if they get left in hyperocclusion. And again, a lot of times if it's mildly in hyperocclusion, you can either adjust it on the crown itself or you can do an enamelplasty on the opposing tooth. Another great feature, there's a unique patent injected molding technique, which also Provides a lot of benefits. So some companies are using milled crowns, and then New Smile is using this molded crown technique. So when you're comparing the injection molding and milling as manufacturing techniques for dental crowns, injection molding offers several distinct advantages that enhance precision, efficiency, and clinical outcomes. For instance, you're able to achieve a thinner cervical margin of just 0.2 millimeters, which promotes better gingival adaptation and aesthetics compared to the thicker half millimeter margins that you'll typically see with a milled crown. Yeah, and that can compromise fit and increase the risk of plaque accumulation. Obviously, can affect aesthetics as well. There's a good picture later kind of showing how that thicker cervical margin can affect the aesthetics. Another benefit, injection molding ensures exact uniformity across all the parts, facilitating reliable trying crowns and consistent results, whereas milling suffers from burr wear that makes controlling uniformity a bit more challenging, potentially leading to variability and rework. While milling does allow for easier changes to shapes and features during production, injection molding minimizes that material waste and is more cost-effective overall, making it a superior choice for high volume, precise restorations without sacrificing quality. So, kind of reviewing those last few things we've been going over. Um, my only the only kind of big negative for me and disadvantage with zirconia crowns was in the past we were getting a lot of fractures back. Some of those from hyperocclusion, probably the majority being from traumas. But since making that switch to New Smile, we really haven't had any yet, which has been great. So another neat thing, New Smile crowns utilize an internal surface treatment that mimics sandblasting to maximize the surface area, enhance mechanical retention for stronger bonding without compromising the crown's structural integrity. But basically, that just improves the durability and the clinical performance of the crowns. This is a great comparison of the gingival adaptation aesthetics due to the thinner margins. Again, 0.2 compared to a lot of the other milled crowns are going to be 0.5 millimeters or larger. Another great visual representation. You can see how thin the cervical margin is on that New Smile crown. And then this next slide has a really great image. But this is a great example from Dr. Jorge Castellon showing the same tooth but with different crowns. And you can see the significant difference due to the marginal adaptation from the uniform thin tapered margin of the New Smile. Yeah, so clearly the one on the right looks much better, much more aesthetic. Yeah, it's a great example. I love this slide. Another great visual representation from an extracted tooth. You can just see how well that margin is just sitting up against the crown of that tooth. Beautiful adaptation, very nice, just superior. Let's see what to use for, hang on, miss a slide? No? Okay. What to use for cementation? There's really no wrong answer. There's plenty of choices. Kind of the best thing is really finding out what works best for you. Um, I know a lot of people that use Fuji too. I know a lot of people who do Keytac, Activa, Biosim. I personally, here, let's go through all these examples. So yeah, there's glass ionomers, there's resin modified glass ionomers, you got resin cement, and you got Biosim. Biosim is a bioactive resin cement with a very strong bond strength, which surpasses glass ionomer, and it matches resin cements and resin modified glass ionomers. So again, it's really about finding what works best for you and in your patients and in your environment. Um, Personally, I do use the Biosim, but prior to this, I was using Activa, which is a very similar product. It's just a bioactive resin cement. And on this next slide, I'll kind of show you the technique that I use. But yeah, so very straightforward. I personally like to fill the entire crown out with cement. And then I also personally cement one tooth at a time. I've got colleagues that do all four at a time for the anterior. I got colleagues that'll do two posterior crowns at the same time. It's really just finding out what works best for you. But I personally like having the control with doing one crown at a time. And I also think it's easier to remove the excess cement when you're doing it one at a time too. Um, I've have some colleagues who like to do all four at the same time, and when I see the some post-op X-rays, a lot of times I see more excess cement than when you're doing it individually. But yeah, first step, I fill the crown up the complete way. I'm going to hold it down with my finger. I like that excess cement coming out. I like to have a big cement collar. It's much easier to remove with the Explorer. So I'll hold it down. I will have my assistant do basically a full cure from the front. Once that's completed and they go to the lingual, I'll use my Explorer to remove the cement collar from the front of the tooth. And then as she finishes or he finishes curing from the lingual, I'll then remove the excess cement from the lingual. So yeah, it's really quick and fast and flawless. Very simple. And again, I personally like to fill it up completely. When it's real bulky when it comes out, it's a lot. I've found it a lot easier to remove. Before I try to do the just perfect amount of cement, and it made it a lot harder to get the excess out of there. Next, so if you've done the introductory course or if you've ever taken one of the workshops, there's this anterior express prep. It's great when you're first learning how to do this. Um, it's not the way I go about it. I think it's great if you need to refresh yourself. This is a good slide to look at. But since we're doing a more advanced course, I'm going to kind of focus more on the way I like to do it. But this technique is great when you're first learning how to do the crowns, how to seat the crowns, making sure the prep's perfect. This is Express Prep Burr Kit. Comes with 3 burrs, black stripe diamond for the super gingival reduction. You got a green stripe diamond for the subgingival reduction, and you got your football diamond for the cingulum. Then yeah, going over again, same thing at the posterior one. We're not going to go into the details here. I kind of want to get more to the cases, show some more advanced stuff, show you the techniques that I use. But again, great reference slide here if you kind of want to look back at kind of a good introductory way to do the prep to make sure you're getting it done correctly. But yeah, this is the preferred burrs that I use. The black diamond is similar to the super gingival black diamond. I'm using this for all my interproximal, my circumferential, and my subgingival cuts. And then I'm using my wheel for the occlusal, the incisal, and for cingulum reductions. So this is the only 2 burrs I'm going to use, and I get great results with this. It simplifies things, it removes steps, makes things more efficient, and it's saving chairside time. My goal is always to do things as efficient as possible because you never know when the child's not going to be on the team anymore. And before we really get into it, I think the most important thing, and if you've seen a lecture before, I've showed this slide. You got to believe in yourself with this. You're learning a new technique. The only way you're going to get better at it um, is by challenging yourself, practicing, and actually doing it in your office. Don't buy the kit and just let it sit and gather dust. You just try it, because doing back-to-back zirconia crowns is not that difficult. Doing canines with zirconia crowns in the back are not difficult. All this can be done on nitrous if you're careful with your case selections. We'll kind of talk a little bit more about that in the next slide. But this is something everyone can master. You got to be confident and you got to be willing to try. And don't be scared of failure. We're all going to make mistakes. I left plenty of crowns in hyperocclusion the first time I did this because you're so close to getting the crown to fit. So you just kind of push it down and it's not truly passive, and so it gets left a little high. We're all going to make those mistakes. You just got to be willing to learn from them and not be scared of having some failures. That's where you're going to learn the most. So case selection, you know, for the first few cases, pulp versus no pulp. If the pulp's going to be involved due to decay, ask yourself, is this the best case to be learning on? I would recommend avoiding cases where the decay is in the pulp for now while you're learning the technique. Um, I don't shy away from pulps now unless there's decay leading to the pulp. The zirconia prep itself will not cause a pulp exposure unless a tooth, usually on the first molars, has a very high pulp horn. So just make sure you're looking at your x-rays beforehand. If you see a very high pulp horn, you can let the parent know. If you don't want this zirconia white crown, there's a possibility we might hit the pulp here because of the anatomy on this tooth. Me personally, if I see a very high pulp horn that I think is going to get hit when I'm doing my occlusal reduction, and if that does happen, I won't charge the parent for the pulpotomy, but I do let them know ahead of time that there's no surprise from the parent. Um, but I would say 90% of first molars, I don't have that issue with the pulp horn. Let's see, zirconia versus SSC. I think the most important thing is also, make sure you're setting clear expectations. If I'm a little unsure of how the patient's going to do on nitrous, maybe the exam was a little iffy, I gave him a Frankel 3. I like to let the parent know, get their permission. If things start going south and I don't think I'm going to have the time to do the zirconia crown and finish the prep, are they okay switching to an SSC? Most of the time, the parents aren't. For the parents that, sorry, for most of the time, the parents are, they understand the situation, especially if they're sitting there watching with you. We allow parents back, so they're kind of part of the whole process. Either way, whether you allow parents back or not, I think it's good to have that clear expectation beforehand in case you do have a case that goes south, because this is, it's definitely not something you want to be doing when the child's not cooperative anymore and doesn't want to participate. So yeah, have those conversations before and then kind of proceed how you feel best. Crowding versus spacing. Yeah, of course, for your first few cases, make sure don't do cases with space loss, don't do cases with crowding. But as you get more comfortable, it's definitely something you can do chairside and do confidently and not shy away from. But obviously not for your first few. Behavior management, set clear expectations, discuss other techniques if needed, depending on the amount of time treatment is needed. You know, um, whether you can offer conscious sedation or general anesthesia, that's a conversation worth happening if things go south and the parent's adamant about having white crowns and you've got to do 6 of them in the posterior. So have those discussions beforehand. So if you do get caught in a situation that you don't have much time to manage, you know what the next step is. A little quick order of operations. So when I'm doing anterior crowns, the first thing I'm going to do, once that patient's on nitrous, patient's is nitrous, the patient's numb at this point, you're ready to start, ice lights in or whatever you like to use. First thing I do, quick test just with water spray. Child's fine, they're not reacting to the noise, the water's not bothering them. Great. Next thing I do, I'm going to reduce the lingual. Patient's still good. Next thing I'm going to reduce is the incisal. And I'm doing all this with that wheel. If I can reduce the lingual and the incisal and everything's going fine, then at that point you're basically committed and then you're going to switch to your other burr. I like to do my interproximal cuts first. And at that point you're committed, like I said, and then you're going to start reducing circumferentially. But yeah, this technique's worked real well for me. Have stopped a few times where the child didn't like the second I touched the lingual, they weren't into it anymore. And so it's an easy spot to stop. Tooth looks fine. You've caused minimal damage. Aesthetics are, there's no issues with the aesthetics. So it's a good spot to start. I've also had ones where it just started to reduce the incisal and things went south. Easy spot to stop again. So yeah, I think it's a good way to test kind of like where the behavior's at and a good way to kind of gauge how much time you're going to have with the patient. And this is for nitrous, of course. For the posterior cases, I start with my occlusal reduction first. After that, interproximal cuts, then we're going to go circumferentially. Yeah, a good thing here, you do the occlusal reduction first. That's like the most important step. If things for some reason went south, you've got that done. And if you had to switch to a silver crown, you can take a 169, break the contacts, and slap a SSC on. Or if you didn't even get to do the occlusal reduction yet, and this is the only tooth that the kid needs treated, you can just switch to an SSC, break the contacts, and basically do like a modified Hall crown. So just set yourself up for success in case things do go south. Let's see, if you are doing a pulpotomy, I personally like to, on the posterior teeth, I personally like to complete my pulpotomy before I do my interproximal reductions. So I'll do my occlusal reduction, I'm going to finish my pulpotomy, then I'm going to do my interproximal reductions, and then I'll cut circumferentially. The reason I do that personally is I just prefer the only heme to be coming from the pulp, just to maybe gauge what the status is on it, if you're unsure from the x-rays or from, symptoms and stuff from the patient and the history. Let's see some more advice. If you're planning an SSC on a first molar and your plan is to do a zirconia on the canine, I would always do your zirconia canine first and then do your SSC after um, for several reasons. One, um, once you've cemented that zirconia crown, if things are a little tight back there and you need to reduce interproximally, you're not going to cause much damage at all that zirconia crown. Now, if you do the reverse and you put your SSC on first, and then you need to make a little bit more space and you hit that SSC, you're going to tear it up pretty quick with a diamond or a carbide burr or whatever you use. So in these cases, I like to do, if there's an SSC next to my zirconia crown, I like to cement my zirconia crown first. Another reason why this is good too, Zirconia Canine is probably gonna take you more time than the SSC. So if you gotta get real quick and get things finished, I'd rather be stuck doing my SSC last than having to do a Zirconia crown. Let's see some more advice. Yeah, so another great way when you're first starting to learn these, and you're still getting comfortable, you're not quite ready to want to do two zirconia crowns side by side. A lot of parents are, who want white will compromise to do silver on the second molars, zirconia crowns on the first molars. So great way to do a couple first cases while you're still getting comfortable. I will, in those cases, I'll do my zirconia first on the first molar and then do my SSC on the second molar after. And again, basically for the same kind of reasons we were talking before. Let's see, let's get to our next slide. Let's see, so this is a 5-year-old. This case was in the OR. I just used this case mainly because I wanted to make a few points on it. This was a private pay patient. We did composite resins on the upper molars, zirconia crowns on the lower molars. In this case, I used needle liner for an indirect pulp cap. But the main reason I'm really showing the slides, I just want to show how much occlusal reduction I'm doing when I do these zirconia crowns. And that's why I'm just showing D by itself because I want to be y'all to be able to see it in reference to E being unprepped. And if you look at this image here in the middle, you can see that I'm pretty much almost reducing almost to the point of contact. So it is a heavy occlusal reduction, and this is not how I first did it. This took time for me to get comfortable that I could take it down that much. But as you get more comfortable with it, it's going to make your life a whole lot easier because I feel like a lot of issues do come from just being a little shy with the occlusal reduction, just because it's just so much more aggressive, but just a little bit more aggressive than we're comfortable with as an SSE. Of course, like we said before, be very mindful of high pulp horns like we discussed before, especially on the first molars. And of course, in this case, the second molar looks a little high, but again, luckily in this case, a pulpotomy wasn't needed. I was able to do it with indirect pulp cap, and I was still able to reduce pretty much almost down to where that contact is. Another great thing with this picture, so you've done your occlusal reduction on that second image. You've taken it down almost to that point of contact. Keep it real simple. You're going to take your next spur. You're going to go subgingivally. Start, do your interproximal reductions. Start it subgingivally and go circumferential, and you just remove the enamel. And all you got to do is keep that burr parallel to the long axis of the tooth. So keep things simple. If it's your first few times, just remove the enamel. You can't go wrong. Just remove the enamel circumferentially. And I think that second image shows that pretty well, but you can see, the whole all the reduction is parallel with the long axis. There's no enamel remaining. This is going to be a very easy spot to place a crown. Got plenty of space for everything. I maybe could have reduced a little bit more on the mesial buccal kind of lying angle, but you can put a crown on regardless. This is going to fit fine every time. But yeah, this is what I do to keep things very simple. Let's see, next slide. Oh, doesn't want to go down. Oh, it's thinking. Oh, that stinks. Let's see. See if we can get to respond. All right, we got to get it restarted, y'all.
Okay, that's fine.
How do we restart this? Turn to meeting. Here we go. Share.
You're still sharing your screen. It's
Yeah.
just going back to PowerPoint. Yeah.
Okay. All right, cool. Let me find this presentation. There you go. Let's see if we can get this to start up again.
There you go.
Does that now look good?
Yeah, that looks good.
All right, let's see if we can get back to where we were. Sorry about that, guys. I hope the video doesn't make it crash again. Getting close. There we go. Okay, here's another case. This is a 3.5-year-old. You can see on the X-ray, D and G, we do have a little mesial decay on there. Again, this is a kid who did good for the exam. I want to set myself up for success. Let's keep things simple. So in this case, if I had gone to the OR, maybe I'd consider doing crowns on all 4 of them. In this case, I want to keep things simple. We're just going to do zirconia crowns on E and F. And while I'm doing the interproximal reductions, I'm gonna go a little heavy and just do a little slice on D and G. And that works great. But let's go ahead and I'll play that video. But yeah, this is done with an isolite.
Tell me when you get. Yeah. Okay, cool.
So spraying that water, kid's fine. Let's do the lingual reduction. He's still doing great. So we're gonna start going a little more. Gonna start my incisal reduction. There we go.
No.
And we're done with that burr. We're not gonna use it anymore. We're switching to that thick diamond. We're going to do the interproximal reductions. Again, this is just the way I like to do it. I'm going to go a little heavy there, do a little smooth on the mesial D and G, keep my life easy for myself and the kid. And then, yeah, we're going to go subgingival, keeping the burr long axis of the tooth.
Yeah, nice thing.
He gave me a thumbs up there or something. All right, done with that one. Starting with tooth F now.
Dr. Harney, I believe the video is not playing for some people.
Oh, okay. Here, I got to click it on this screen. All right, sorry
There
guys.
you
Here,
go.
we're gonna start it over. Apologize. So, okay, spraying the water. He's not reacting. He's doing fine. So I'm gonna go ahead and start doing that lingual reduction. Again, if things go real south here, he's gonna be able to leave with no pain, no damage to the tooth. Everything's gonna look fine still. Now we're going to the incisal reduction. Again, if things went south, still would be okay to stop right now. But he's doing great. So we're gonna switch the burr. Gonna go to those interproximal reductions. And I'm gonna, at this point, we're going subgingival for basically the whole time. Doing interproximal reductions. I'm gonna go a little heavier on the mesial of D and G to remove that little bit of decay right there. And then we kind of start going around circumferentially. Most important things. Let's see, what was it? Oh, peace sign, nice. Make sure you're going subgingival. You don't need to be shy with it. You can see I use a pretty thick diamond here, but I'm trying to keep things efficient. Saves time for you and the child. Again, we're going circumferentially, we're going subgingival. Keep everything along the long axis of the tooth. Nice straight parallel lines. I like to round the incisal edges. You don't necessarily have to, but it's just something I personally like to do. Just kind of looking everything over, making sure I like how it looks. And there we go. And so, start to finish there, that prep time was a little less than 2 minutes. So, it's, you can kind of gauge what you're able to do on the kid based on their first few responses. So that's about 2 minutes. I'd probably say in another minute, we've got both crowns fully cemented, cement cleaned. He's ready to leave. He's ready to get on oxygen and then leave. So about probably 4 minutes total at most. When I time myself so maybe like 3 minutes, but when I time myself for D, F, and G, even when I had to flip the isolite, it's about 6 minutes from starting the water spray to cementing the crowns completely. Again, that comes with time. It comes with practice, but you can get there really quick, and it's a great thing to be able to offer your patients. But good result. The second video is going to kind of show just the cement. So again, I like to fill mine up completely. I seat them one at a time. And then I let them cure from the front. I remove that collar. But yeah, they've already cured from the front in this case, but you'll see another example. But collar, when you have it nice and thick like that, it comes off just so easy. Let's see. Let's go to the next video. Make sure this, there we go. Now make sure to press on this side. Okay, so this is another case. This patient had just turned 5. They had previously had GA for D, F, and G when they were 2.5 years old. But fortunately came back, had interproximal decay on the canines to the back. So, but in this case, we were doing zirconias on C, H, M, and R, and then we're doing SSCs on A, B, S, and T. We'll go ahead and start this video. But again, I like to do my zirconia canine first. And this video might be sped up, I forget. But anyway, so I'm going to do everything I can with this burr right now. So doing my occlusal reductions, I did my incisal reduction, I did my lingual reduction on the canine. And then doing the exact same thing on the top. Everything I can with this burr all at once so I don't have to go back to it. So incisal reductions, cingulum reductions, occlusal reductions. This video they had taken a couple, so I had to kind of splice them together. And again, everything's a little sped up, I believe. But yeah, doing those circumferential reductions here. I'm going to remove a little bit from the mesial of the first molars. Actually, I'll go ahead and do my interproximal reductions everywhere here. So that's all the circumferential on the canine, and then all the interproximal reductions on SSCs, going back up to the top and just kind of repeating the same process. Remember, you're on the long axis of the tooth. Make sure you're subgingival. Canines are great. There's a lot of tooth structure there. There's a lot of space between the enamel and the pulp. You don't have to be very shy. You don't have to be shy with your reductions. Okay. Oh, okay. The prep part was not sped up. This part is where we speed it up. But yeah, so curing from the front. I'm gonna remove that cement collar. That's all off. Again, I like it to be nice and large so it comes off real easy with my Explorer. Same thing on the lingual. If you're ever not sure, just dry everything really well interproximally and you'll see if there's a piece of cement in there still. A lot of times when you put these canines down, you'll see things are a bit tighter on interproximally now. So I like to go one more time back through with that burr just to make sure that space is opened up for the crowns to fit behind it. And again, these were SSCs going behind. Now we're putting that upper canine on. Cleaning the cement collars. Again, nice, big, thick, pops off easy. Slicing that one more time just to make sure there's good space there for that SSC to go down. Yeah, and anyway, so yeah, that's so 2 zirconia canines and then 4 SSCs to follow. The prep time for top and the bottom was around 2 minutes. So again, you can do this real fast, real efficient. There's no reason why cases like this can't be done on a nitrous. Let's see. And again, this all just comes with time and confidence. Let's see. All right, next case. Oops. So this was a 7-year-old, only having chewing pain. This was her second treatment appointment. She was F3 for the exam. In this particular case, we were doing an MOD on K. We were smoothing the distal of H while we were doing our crown prep on I. I and J were getting pulpotomies with zirconiums. But let's get to that video next. All right. Okay. And in this video, I'm not going to show I did my composites first already on K and L. Now we're just going straight to crowns. Did my occlusal reductions. I'm going to start my pulpotomy, kind of unroofing the pulp chamber here. Going to put our sterile cotton pellets in there next. And this is her second time. She'd already done the right side. So she got a little upset during this, but things were still safe. Mom's sitting right next to us this whole time. Felt real confident we could still do a good job. Taking those cotton pellets out. We're going to put Neo Putty in. Pulps are done. And again, I like to do my pulps before I do my interproximal reduction, just so I know exactly where all my heme's coming from. And we did interproximal reductions. We're going circumferential. We're going subgingival. Wish I had a little bit of a better video with different angles and some photos, but again, this is, this is an anxious patient on nitrous, so time is of the essence. The second molar crowns are do feel a little larger, a little thicker to me. I like to cement those first. That way, when I go to seat the first molar, for some reason it's a little tight, it doesn't fit well, I can take a little from the canine, I can take a little from the mesial of the second molar and get that first molar down. That wasn't the case in this one, but it's just I always like to have an out if I need it, if things aren't working out in the moment. If you were to do the first molar first and then try to seat the second and it's a little tight, it's not sitting down fully, the last thing you want to do is have to take from a 6-year molar to make space. She's getting a little upset here, but we're about to be done. But again, she already did KMOD, she did LDO, but she did great. And yeah, total prep time there with the pulps, right at 3 minutes. So again, it can be done. You can get very comfortable and confident with it. It does take time. And my main goal here is just really to show everyone that with time and practice, anyone can do this, and it's a great service to offer your patients, especially when they prefer a more aesthetic option. All right, let's see the next case. All right, so this is about as advanced as you're gonna get. I was kind of reviewing this case today, to pull up the X-ray to add to the PowerPoint. Yeah, and I looked up the date. I was assuming I did this in general anesthesia, but I actually did this case on nitrous, which surprised me because I didn't remember doing that, and this is a pretty difficult one. Let's see, let me get to over here. But this was this is a 5-year-old patient. Again, this is a very advanced case in my opinion. Definitely one that I'd recommend doing not on nitrous until you're very comfortable. This patient had 2 previous restorative treatments prior, combinations of fillings and crowns in the posterior. That was done like over a year ago. We had been observing the decay in the anterior, and things had just gotten a little bit bigger. So we went ahead and we were hoping we could watch things till teeth got loose and exfoliated, but in this case, we did have to go ahead and do some full coverage restorations on D, E, F, and G. Well, let's kind of talk about it some more. So this one I'm just going to use photos because it would be a lot to kind of explain. So good. It's a great example for several reasons. First, if you kind of can see how crowded and how rotated D and E are, G is a little lingually inclined. But because of the rotation of the crowns, there's certain areas when I'm prepping this that are going to receive a heavier prep than normal. And then also because of the crowding, there's interproximal reductions needed after cementing a crown. So yeah, difficult case. Don't do it on your first one. Do it when you start feeling very comfortable. When you feel comfortable, removing from crowns if you need to make space as well. If you were to just do a standard prep on all these teeth, they wouldn't sit perfectly aligned with one another. So for example, looking at tooth E and F, I will prep heavier on the distal half of the crown that is rotated to the anterior. So on E and F, on both these, I'm going to go heavier on my prep on the distal because they're sticking out. Much more light of a prep on the mesial half. Number D, of all these 4 teeth, D is the one that's kind of in the most perfect alignment. So you're kind of just doing your standard prep on D. For G, you can see it's a little lingually inclined. So my prep's going to be a little heavier on the gingival third of the crown than the remaining upper 2/3 of the crown. That upper 2/3, you're not having to prep very much. But basically, once you see that second slide here, you'll see that, you're creating, an like the long axis of the tooth that's very artificial, wouldn't match it naturally. But that's how you're going to be able to seek these crowns so that they're aligned and they're straight and things aren't overlapped and rotated. Overlapped and rotated, you're gonna have a very hard time trying to seek the crowns, and you're not going to get an aesthetic result. You could try to sit it that way, and the parent's going to say the teeth didn't look like that beforehand, even though it did. So some tools and tricks here to take these cases that are rotated and crowded and make them kind of, a pretty good result, nice and straight and aligned for how difficult it is. Let's see, what was I going to say next? Okay, so we go down here to this third picture. Went ahead and cemented E here, and you can see how little space exists between E and F, a little bit more space between D and E. This next image is after I've already, here what I've done, I would have sliced a little bit on the distal of E. I might have even reduced a little bit on the mesial of D outside of the mouth, and I've made enough space where I can cement this D in. Now, if you compare this image to the image up here, you will see how much I'm able to go in here and slice right here and create a lot more space to fit the next crown to get F in here. And that final step is, again, here's F fully cemented, and I have to go back in here. You're going to reduce on the distal of F, maybe even on the mesial of H if you have to. Make your space, get the crown done. Nice, great result considering what we started with. But again, difficult case. I believe in this case, I even had to do, I forget, maybe it wasn't this case, but I think this was about 20 minutes. So it's, a lot of cooperation, a lot of time needed to get everything just right. So be careful in cases like this, but know that it can be done, especially when you got a nice cooperative kid. But yeah, very nice case. These lasted until the tooth exfoliated naturally. Let's see, let's go to our next case. We're getting a little close on time, so we'll kind of speed things up. Yep, this is just an example of a single tooth replacement. It can be done. Great aesthetic result. Parents are going to be happy about that all the time. Some more advanced cases, supernumeraries. I've had a couple of cases where you've got 5 or 6 upper incisors. I don't have a picture of it here, but if you ever need to, you can use the lower U's as your extra crowns to make them all fit and look aligned and fit very nicely. Another trick, if you got squared lower incisors and the U's are more of a narrow shape, if those aren't fitting well for you, you can use the upper lateral zirconia crowns to do on the lower anterior teeth when they're real squared like that. And yeah, just a couple examples of cases here. Couple more examples. Couple more examples. Still more. This one shows kind of the SDF. Can't see anything through the crown, which is great. But again, top 5 tricks. Don't be shy with that occlusal reduction like we talked about before. Remove the enamel. Keep things simple. Make sure you have a true passive fit. Make sure you're checking your occlusion. If you get in a situation where, a tooth's a little hyper occlusion, but it's still kind of clinically acceptable, know that you can do a little enamelplasty on the opposing tooth if that's your only choice. You don't have much time left, or you can do a little bit of reduction on the crown itself. And then case selection, we kind of reviewed that quite a bit, but those are kind of the most critical things to me, and that is about our time. So I think we'll go to Q&A now, and I'm excited to see what questions you guys have.
Yes, thank you so much for that, Dr. Harney. That was great, very informative. And we do have a couple questions. If anybody else has questions, you can drop them on the Q&A function.
And I apologize, some people are raising hands. Let's see, I wish there was a way to answer questions in the moment, but we saved it for the Q&A.
Yeah, exactly. We have a question from Dr. Bryce Evans. Are you prepping one tooth at a time when you're testing?
Testing as
I'm
in
assuming.
first learning how to do them?
I would say so. It
Oh,
could have been from one of the
okay, I
slides.
see what you're saying. When we're testing to kind of see the patient's behavior. No, I'm just if we're doing D, F, and G, then if we're doing D, F, G, or we're doing E and F, we're doing all the same reductions at the same time on everything. Just keeping things efficient, not switching burrs. I've only had one time where I did D and E in one appointment. Patient went south, and we had to have him come back and do F and G. Luckily, we got that done because that would have been a really tough situation to be in. But yeah, I've had one instance where I wasn't able to get it fully done after kind of testing the patient with that lingual reduction, incisal reduction, and then with the posterior, yeah, we're doing everything the same time on every tooth.
Okay, great. Dr. Crystal Hayes has a question. Did you use something to control the bleeding? Could have been from one of the
yeah, we
slides.
didn't even get into hemorrhage. Yeah, I took those slides out just because there's so much to talk about with the examples. So it's really, there's so many options for hemostasis. It's really just finding out what works best for you. For me personally, since when I cement my crowns, I only do one at a time. I feel comfortable just with gauze pressure, and I haven't had an issue with that. Some people like ferric sulfate, some people like to use a little epinephrine. So it's just finding out what you want to do, how many crowns you're comfortable cementing at a time. I like to keep things very simple and efficient. So I like to do one tooth at a time so that gauze pressure is more than adequate.
And then Dr. George Gutierrez, when do you decide to use narrow posterior crowns as opposed to just prepping more?
I would say for the most part, so like I said before, a few things. I don't think there's very few times where I need to over prep a tooth to try to get it to fit. You're pretty much only using the narrow ones if, let's say, you got a kid with very broad contacts, large teeth. You might need to use a narrow on the D. And then also for space loss, of course. If you've got space loss from a lot, I should probably find a good case to put that in here to show a space loss one with a narrow tooth. But yeah, you got a large cavity, you're going to be doing a pulpotomy. The E's, the second molar is already shifting into the first molar. If you can already see that in the x-ray, you're probably going to need a narrow crown. And I would highly recommend, if you really want to start tackling those more difficult cases, I would definitely have those on hand. Because the last thing you want to do is get in that situation where you don't have a narrow crown and then you're having to do some heavy reductions on the teeth adjacent to try to get something in there. But yeah, I hope that answers your question.
Awesome. Dr. Rashida says, can you review again which burr you like to use for reducing or adjusting on the zirconia?
On the zirconia itself. Yeah,
Yes.
I just use like a white polishing, the white polishing stone usually works pretty well for me. You could also use like a football diamond. So it really depends. I've kind of used both depending on the situation. But a diamond will work perfectly fine if you need to do a little bit of a heavier one if you get caught in a situation. But you can also use the white stone if you're doing something lighter.
Awesome. Dr. Butler, any clinical tips for burr guidance when prepping subgingivally for posterior zircs?
Yeah, I mean, I think the most thing is just being really aware of the angle that your burr is and just truly just visualize the angle that that pulp will be in the long axis of that tooth is, for the anterior, that is. But yeah, just visualize that long axis of the tooth, make sure you're parallel with it, and just be very aware and conscious of your hand and have control of it. Make sure you have a finger rest. Yeah, the thing is just having control and just a little awareness of how you're tilting that burr and stuff as you're moving around. And as you get more comfortable, you'll get to the point where you're going to be able to hold your hand steady always, for the most part, within a reasonable range to keep things basically parallel to long axis. Just lots of self-awareness at the beginning when you're learning how that feels in your hand.
Okay, and then we have Dr. Hayes. What's the best way to decide pricing for the crowns?
Yeah, it really depends what you're comfortable with. I didn't get to talk about this, but what I would recommend when you're first doing these and you're starting to get comfortable with them, I would literally, if a parent wanted an SSC, I asked them if they were interested in a white crown when I was first learning. They'd say yes. I'd tell them, I'm not even going to charge anymore. I'm just going to do it for the same fee of the SSC. I don't tell them why, but it's because I'm still learning these. So that's a great way to practice these. You don't need to upcharge them when you're first starting. Once you start getting really good at them, I think $100 more than a silver crown, I think is a fair fee to set. And any parent that wants a white crown is not going to bat an eye at $100. And the nice thing too is you don't have to sell these. I don't sell them. I just, I tell a parent, we only do white for the anterior. For the posterior, it's silver or white. It's up to you. It doesn't matter to me. And of course, if it's a kid that's very anxious, we'll have those conversations. But yeah, I mean, before you can even say white, the parent says white. So it's you don't have to sell these things. They'll sell themselves because the parents know if they want them.